Hello everybody, so thank you for watching my video today, and in today's video we're looking at the high yield STIs for finals as part of the obstetrics and gynecology edition. So let's get started. So the Medicine Guide aims to support medical students throughout their entire journey at medical school. So I've made a series of videos dedicated on being as successful as possible in medical school, such as how to be successful during the pre-clinical years, how to be successful during the clinical years, how to get the most out of GP placements, how to get the most out of hospital placements, how to succeed in clinical OSCEs. Also, I've made a paediatrics edition focusing on the high yield topics that crop up in finals, such as a child presenting with vomiting, congenital heart diseases, rashes, limping child, genetic conditions, and a child with a mass. Now this video is used in conjunction with other videos to help support medical students for preparing for the high yield obstetric and gynecology conditions that crop up in exams, such as the high yield chronic abdominal pain, high yield gynecological cancers, high yield acute abdomen, high yield obstetric emergencies, and high yield STIs for finals. So without further ado, let's get started. So in today's video we're going to look firstly at bacterial vaginosis, then we're going to look at Trichomonas vaginalis, Chlamydia, Gonorrhoea, Candidiasis, Genital Herpes and Syphilis. So I've highlighted bacterial vaginosis in this dark purple colour because it's not strictly an STI, however it is a disease that's more commonly found in women who are sexually active. And similarly, Candidiasis isn't necessarily an STI as such, but I've really included it as part of completion of covering all of the different STI topics. So without much further ado, let's get started. Okay, let's get started with bacterial vaginosis. So like I previously mentioned, bacterial vaginosis is not an STI, however it is more common in young sexually active women. So bacterial vaginosis is caused by a Gardnerella vaginalis overgrowth. So normally I would have discussed the signs and symptoms, but I think the key signs and symptoms of bacterial vaginosis is found within the Amsel's criteria. So if you remember Amsel's criteria, then that will put you in good stead for the exam. So women will often complain of a thin white vaginal discharge. Now, one of the common questions that they ask for any SBAs regarding STIs is that they will give you a list of different tests that could be performed for a particular condition. So if you have a SBA on bacterial vaginosis and it gives you a list of different tests that you can perform, it's really important that you remember a high vaginal swab is performed for bacterial vaginosis. So once a healthcare professional has performed a high vaginal swab, the results are then sent off to the microscopy team, and as part of microscopy, clue cells or stippled vagina epithelial cells are identified. Now, clue cells and stippled vagina epithelial cells are exactly the same thing, and the only reason why we have two different phrases is that in the SBA it could refer to either phrase. It could describe it as a clue cell or a stippled vagina epithelial cell. So that's why I've included both phrases, just so you can be aware of that on exam day, and hopefully you won't be taken by surprise when you see those phrases. So it means exactly the same thing. So if you have a look at the picture in the far right hand corner, you can actually see that you've got the vagina cell and you've got bacteria stuck to them. And if you have a look at the picture in the bottom corner, that again is just a close-up of the clue cell or the stippled vagina epithelial cell. And the vaginal pH will be more than 4.5. And finally, as part of Amsel's criteria, there is a positive whiff test. So with the addition of potassium hydroxide, then this creates a fishy odour. Now, the management of bacterial vaginosis is very simple, very easy. It's treated with metronidazole. Okay, So the next condition is Trichomonas Vaginalis, and this is an STI. So it arises from unprotected vaginal intercourse. So the hint is in the name, Trichomonas Vaginalis, vagina, vaginalis, unprotected vaginal intercourse. And if you've got multiple sexual partners, you're at greater risk of developing this. So it's caused by an infection with Trichomonas vaginalis. So hopefully that should be quite easy for you to remember. And another key fact is that Trichomonas vaginalis is a flagellated protozoan parasite, and that's something that you definitely need to know for your exams because it crops up again. So you might have an SBA describing Trichomonas vaginalis, and rather than the SBA asking you what causes this condition, they might ask you to classify the type of organism that leads to this condition. So in that situation, you would need to find the answer choice with flagellated protozoan parasite, tick it, and move on to the next question. Okay? So in terms of signs and symptoms, so symptoms will typically present within 28 days of the initial infection. There will be a thick, frothy, yellow-green vaginal discharge, vulvar vaginitis, and a strawberry cervix will be described. So strawberry cervix is describing this punctuate and papilliform appearance of the cervix, and if you have a look at the picture on the far right, hopefully you'll be able to appreciate that. So most men are asymptomatic to Trichomonas vaginalis and typically present as partners of infected women. In terms of tests, the vaginal pH is more than 4.5, and microscopy of the wet mount will show mobile trophozoites. Now again, these are just key phrases, key buzzwords to help you get the highest marks possible in the exam. And in terms of management, we offer metronidazole. So I hope that you can appreciate that bacterial vaginosis and Trichomonas vaginalis to a certain extent are quite similar presentations. So they both have a vaginal pH more than 4.5. They're both treated by metronidazole. However, bacterial vaginosis is not an STI, and it has a very positive whiff test and clue cells present on microscopy, whereas Trichomonas vaginalis is an STI. It's caused by unprotected vaginal intercourse. Microscopy of the wet mount shows mobile trophozoites. It presents with a strawberry cervix and a thick, frothy yellow-green discharge. Okay, so just remember these key phrases, key buzzwords, and hopefully you'll get as many marks as possible in the exam. So now we're going to look at chlamydia. So chlamydia is the most common STI in the UK. So it's caused by unprotected vaginal, anal, or oral intercourse. Chlamydia can occur as a co-infection with another STI, so typically gonorrhea. So gonorrhea and chlamydia tend to co-present together. And another risk factor of chlamydia is the lack of barrier contraception, because condoms are important in terms of preventing pregnancy from occurring, and they're also very good at acting as a physical barrier to reduce the transmission of STIs. So men with chlamydia will suffer from urethral discharge, dysuria, so that's pain on urination, and testicular pain, whereas women with chlamydia will present with cervicitis, so that's inflammation to cervix, cervical excitation, so during a pelvic exam, when the healthcare professional presses on the cervix, the woman will suffer from pain, so that's what cervical excitation is alluding to. Also, the woman might suffer from intermenstrual or postcoital bleeding, so that's bleeding in between her period cycle, or bleeding after intercourse, so postcoital bleeding. In terms of tests, so women, the first line investigation is to do a vulvovaginal swab, and in men, the first line investigation is to do a first pass urine sample. The gold standard test is the NAT test, so that stands for Nucleic Acid Amplification Test. Now it's really important that you're clear in your mind about what will be your first line investigation for chlamydia and what is your gold standard, because that's something that does crop up time and time again for exams, so please keep this in the back of your mind. And the management for chlamydia is azithromycin. Previously doxycycline was used, but I believe it's gone out of fashion, and azithromycin is what is more commonly used now for chlamydia. And for partners of infected patients, they need to be treated empirically whilst waiting for results. Okay? And now gonorrhoea. So gonorrhoea is the second most common STI in the UK after chlamydia. Risk factors for gonorrhoea involves unprotected vaginal, oral, or anal intercourse, multiple sexual partners, and a previous history of gonorrhoea poses a patient to be at greater risk of developing a future gonorrhoea infection. So gonorrhoea is caused by a Neisseria gonorrhoea infection, so it's highlighted in blue. You definitely need to know the underlying organism, and this type of organism is known as a gram-negative diplococcus. So again, that's been highlighted, so please remember that. So men will suffer from urethral discharge, dysuria, epididymal tenderness. Women will suffer from a thin, watery green, yellow vaginal discharge, mucopurulent endocervical discharge, intermenstrual postcoital bleeding. In terms of tests, similar to chlamydia, we need to do first-line investigations and then gold-line investigation. So first-line investigations for gonorrhoea in a woman is a vulvovaginal swab, but in a man it's a first-pass urine sample, and we do the NAP test as the gold standard. And we need to do a full STI screen because I previously alluded to the fact that chlamydia and gonorrhoea often co-present. So it's quite important to identify if you're just dealing with a gonorrhoea infection, or if you're just dealing with a chlamydia infection, or if you've got both chlamydia and gonorrhoea occurring. And in terms of management for gonorrhoea, we offer patients intramuscular ceftriaxone. Now, if the patient is needle phobic, so therefore an intramuscular route of administration would not be ideal, we would give them oral cefixamine and then oral azithromycin. So it's important that you are aware of the treatment for gonorrhoea. So you need to know that intramuscular ceftriaxone is given, but you also need to know the alternative medication that's given to patients who are needle phobic, because that's quite a typical exam question. And similarly, for partners, offer them testing and treat them empirically whilst waiting for results. And a test of cure is offered in all patients treated with gonorrhoea. So Candidiasis now. So Candidiasis is essentially a fungal infection caused by Candida. So risk factors involves patients who are essentially immunocompromised, so they might have HIV, they might currently be pregnant, and they might be suffering from diabetes. Antibiotics is something that's important. So in the SBA, it might allude to the fact that a woman has had a chest infection, so she's suffered from a community-acquired pneumonia. She's taken some antibiotics for her pneumonia, so let's say the doctor gave her perhaps amoxicillin or doxycycline, and a few weeks later she's presenting with symptoms similar to Candidiasis. So that's a sort of typical SBA that you might get for Candidiasis. So let's go through the risk factors again. We've got diabetes, pregnancy, and immunocompromised patients, and antibiotics. So typically, patients might develop thrush or Candidiasis after using antibiotics for treating another infection. So I previously mentioned the pneumonia. Okay. So it's caused by Candida albicans. So again, that's highlighted in blue, so please remember that. It's high yield for exams. And Candida albicans is most commonly known as thrush. So these patients will have a cottage cheese-like discharge. Sometimes I think it's described in SBAs as a curd-like discharge. They'll experience itchiness, vulval erythema, and fissuring and satellite lesions. Intensive test, a high vaginal swab is needed, and the management involves local clotrimazole or oral itraconazole or fluconazole. And now we're going to look at genital herpes. Risk factors involves multiple sexual partners and direct skin-to-skin contact, so that might be via vaginal intercourse, oral intercourse, or anal intercourse. So genital herpes is either caused by herpes simplex virus 1 or herpes simplex virus 2. So herpes simplex virus 1 typically leads to patients suffering from genital herpes and cold sores, whereas herpes simplex virus 2 only leads to genital herpes. So a typical SBA is that a patient has had a moment of passion with her partner, and her partner happened to have a cold sore at the time. So the cold sore is alluding to a herpes simplex virus 1 infection. Moment of passion, so would involve some degree of skin-to-skin contact, and therefore that's the sort of stem that's suggesting to you that this patient could be suffering from genital herpes. Does that make sense? So now we're going to look at the signs and symptoms. So genital herpes are actually very, very painful. So it presents with painful genital ulcers, and 20 days later these ulcers will crust and heal. There might be a mild flu-like illness prior to the presentation of genital herpes. So intensive tests, we do a pap smear or a smear from an open sore, and genital herpes will present with 3 M's. So multinucleation, margination of the chromatin, and moulding of the nuclei. So again, just be aware and familiar of these buzzwords, because that will help to point you towards the direction of genital herpes and help you get those high marks in exams. And we can do PCR to help differentiate if the underlying cause is due to a herpes simplex virus 1 or herpes simplex virus 2, because either of these strains can lead to genital herpes. And in terms of management, we give aciclovir, and we would perform an elective C-section in pregnant women where the infection presented after 28 weeks of gestation. Okay. So syphilis. So the risk factors of syphilis involves unprotected intercourse, multiple sexual partners, HIV infections, and needle sharing with a known syphilis patient. So syphilis is caused by Trichomonas pallidum, again highlighted in blue, please remember that. So syphilis might present along a spectrum. So syphilis might initially present as primary syphilis. So these patients will have what's described as a chantre. So a chantre is a painless ulcer at the site of sexual contact, and they may also present with painless local lymphadenopathy. So if you have a look at the picture in the far right, that's an example of a chantre. So whenever there's any SBA involving a painless genital ulcer, that should hopefully switch on the light bulbs in your brain and make you think, aha, this is a chantre, and this is very classic of primary syphilis. So you can tick that answer and move on to the next question. Okay? And then secondary syphilis presents 6 to 10 weeks after primary syphilis. So patients will have rash on their palms, their trunks and their soles. They'll have a buccal snail tract ulcer and condylomata lata. So if you have a look at the top right, we've got snail tract ulcer, and at the bottom there's condylomata lata. So this is a painless warty lesion found on the genitalia, and it occurs in secondary syphilis. So let's focus on the signs and symptoms again. So late syphilis, it's just when the syphilis is presented 2 years after infection. Now tertiary syphilis is something that's very examinable and something that I want to focus upon a bit more. So patients present with gummers. These are granulomatous lesions found on the skin and the bone. And these patients will present with neurosyphilis. So neurosyphilis is an umbrella-like term which describes some of the features that patients will suffer from. So they'll suffer from Argyll-Robertson pupils and Tapes dorsalis. And I'll talk about them in a bit more detail in just a few seconds. And other symptoms that are suggestive of tertiary syphilis involves ascending aortic aneurysms and aortic regurgitations. So this is an example of gummers. Now, Argyll-Robertson pupils is something that's highly examinable in both ophthalmology and understanding syphilis as part of obs and gynae. So in Argyll-Robertson pupils, accommodation reflex is present, but the pupil reflex is absent. So when you're shining a light in the patient's eye, normally when you shine a light, pupils will constrict, but in Argyll-Robertson pupils, your pupil reflex is absent, so rather than constricting, the pupils will remain dilated, and that's quite important. And Herpes dorsalis is essentially a presentation where patients present with these symptoms 20 years after the initial infection with syphilis. So this involves the dorsal columns, so there's a loss of vibration and proprioception and loss of fine touch, loss of sensory ataxia. These patients will suffer from a urinary incontinence and have a positive Romberg test. So if you ask them to close their eyes and stand still on the spot with their eyes closed, they'll fall over. So that's indicative of sensory ataxia. Okay. Now, in terms of tests for syphilis, dark ground microscopy of the chancery fluid identifies the sporosity in primary syphilis. You can do PCR and troponin ELISA. So you might find an IgG or IgM, and this remains positive for life. And in terms of management for syphilis, we need to give penicillin. So sometimes in exams they might give you an option of penicillin 5 or benzyl penicillin. Now, because they're both penicillins, you can give either of them, but I just wanted you to be aware that you could give penicillin 5 or benzyl penicillin. As long as it's penicillin, that's the most important thing, and that's what's used for the management of syphilis. So thank you very much for watching my video today. I appreciate it's been quite a long video. I'd just like to say, if you've enjoyed my video today, please give me a thumbs up, please subscribe to my YouTube channel, please share with your friends, and I wish you all the best for your final exams. I just wanted to quickly spend a few seconds talking a little bit about the NHS cervical smear programme. So a third of women in the UK don't attend because they feel quite embarrassed and self-conscious. However, I just want to reassure you that when you go for your cervical smears, the nurse or the healthcare professional involved in taking the smears is entirely understanding of some women's aversions, and they try to put you at risk. They try to put you at ease. They explain the entire process quite thoroughly, and the smear test only lasts 5 minutes, but the implications of not having a smear test and potentially developing cervical cancer is something that's life-changing. So I just want to encourage young women that are watching today to please attend the smear tests. Okay, so thank you for watching my video today, and I wish you all the best for your final exam.